You can see my screen, I suppose.
Yeah, we can see it.
Awesome. Okay. So, so today we are, as our ID group, we'll really just go through some antibiotic review. I know we do a big antibiotic orientation and review in July, so I'm not going to try to rehash all that. A lot of today, I want to kind of go through any updates that we've had in the recent year, and specifically any updates that have come about with Epic and so forth. So, but I want to give y'all time at the end as well to ask questions that y'all have that come up a lot that you might just want to kind of ask us for clarification or what have you. So, no further ado. So, first thing I want to make sure that everybody has or everybody knows about is the Spectrum app that we utilize here in the Midlands. And again, this is what we try to put all of our guidelines on that are antimicrobial based. We try to have all of our antibiogram data on here, and as well as any dosing that we prefer to use locally here. So again, I think that it is it benefits everybody to have this downloaded. It is free to download, and you just go to the App Store wherever you're at, and download Spectrum Antimicrobial, and it's there. You just, I think I have it. Yeah, here you just find it there. You open up the app, and then you choose Prisma Health Children's Hospital. You'll see a long list of hospitals. Actually, let me show you here. So what happens is you'll see a bunch of different hospitals. You'll click ours. If you show you this spectrum.app /prisma/children's actually is a hyperlink that you can actually use to get to the desktop version, and you can bookmark that wherever you're at. And so you can almost use this like Lexicomp in a way. It's, you know, it looks exactly, it mirrors the app. And so if you're at a computer and you don't, you know, if you want to just pull it up that way, you can do that. And again, make it maybe potentially easier to see different dosing or what have you through the app. So I say that all because with Epic, I know there's been some challenges when it's come to the new layout of dosing, and we've seen this on our end. And I'll tell you, there's a lot of discussion when we were going live with this of what dosing buttons to allow. And my goal is to streamline those as appropriately and effectively as possible as time goes on. My goal is to kind of hit every antimicrobial that we have and tailor those down. So one thing is that a lot of the doses that are there were given to us from what the upstate used. And unfortunately, they choose to basically put in every dose that is available on Lexicomp, which comes with a lot of issues. We know that allows for a lot of buttons to be there and allows for a lot of issues with error and choosing the wrong dose and the wrong button for the incorrect treatment. We've seen that a lot. A lot of people are picking the first button that's right there. And that's causing for a lot of underdoses and just not appropriate. So my goal, like I said, is to kind of go through everything and really take out a lot of those low doses or doses that just aren't appropriate in most cases. But again, it has to be agreed upon between us and the upstate. And so that's not just a matter of our stewardship program kind of making those decisions. It's more than that. But with that being said, just be cognizant when you're ordering to try to go to the app to look and make sure that what is in our app and what we like to utilize for dosing is chosen. I will tell you that I went through our app and at least made it. So you'll notice too that there's a lot of mg per kg per day and mg per kg dosing. And basically that comes from Lexicomp. So if Lexicomp chooses a drug and says, okay, for ampicillin, we're going to dose it in mg per kg per day. In what is in Lexicomp, that is what is in Epic. I tried to fight that and just change everything to mg per kg per dose, but that did not go over well. So with that being said, I made the decision to at least update our app so that y'all could at least see that and mirror that. So again, when y'all can, I think it's getting a good habit of making sure that what you're entering into Epic matches what is in. And so to make sure that they match. Okay, so with that being said, that is that part of it. Another part is you'll see now we have indication-based dosing or indication-based ordering, which is a good thing. So that is nice because that at least helps us even when we're seeing the indication that's chosen and the dose doesn't match that and it's way off, we can make sure that we're making the appropriate recommendations to adjust those doses. And it helps with a lot of other things as far as making sure we're ordering the right drug for the right disease and all that stuff. So that's good. There's probably been a few times that you all have seen so far that you have noticed that there is potentially a restricted drug that you want to use, and Epic does put more of a stop on those restricted antimicrobials, which then require you to choose either Dr. Birch or Dr. Widener's name and or myself or Andy's name for approving providers in any of these antimicrobials that you see here. These are what are restricted throughout the system, both peds and adult. So a lot of these are not things that we use, but they are restricted. So these are something that you would have to talk to us and get approval for. So basically, these are what we would consider our targeted drugs with a little more restriction. So again, I don't know if y'all have seen this yet. I know we had a kid yesterday that they requested Pramivir. It was a family medicine patient, but so if you ever go to order a drug, one of these drugs, you'll be left with a hard stop of talking to Peds ID or Peds stewardship for those. So that is a difference in Epic as well. So just to kind of keep you all right. Well, yes. So I would assume so. So outpatient stewardship and the Epic process, that is another thing that I know that has kind of been different. So as y'all know, and I think there are some workarounds that have been figured out, but pharmacy is supposed to review and release all discharge prescription orders for the majority of patients that are discharged from the hospital, which is good and bad in ways. Obviously, we're still trying to figure out workflows for that, but in a antibiotic stewardship perspective, that is helpful in that we can actually see what is being discharged and if we can help with those, or if we're seeing anything that might, be going out on something that shouldn't be, or durations are too long or what have you, we can intervene on those and assist with that process. So again, that's a working process, but it is a difference in Epic that was than in Cerner. So I think it'll be good in the end. It's just, I think right now we're just kind of figuring out that process. But again, that helps us see what the patients are going out on for. Another thing I will mention with Epic is you'll start seeing a lot more notes from us because we're able to more easily add in our notes into Epic than we were into Cerner, and they will show up in your notes or progress notes section. And those will basically state whenever there is a decision made or whenever there is a recommendation made from us as far as duration, we will put those notes in. And sometimes they will say basically that we would recommend this. It might not be what will be the plan, but it is the recommendation from a stewardship perspective. So just be mindful of that. It's not we're disagreeing potentially, but it's something that, this is what we would recommend based on the available evidence that we have. Does not mean that our differences are not appropriate or not, are appropriate either way. So, okay. So that's kind of the EPIC, kind of a few things that we've noticed with that. So, and again, keep some questions in mind if there's anything that that you'll have for that when I'm done going through some of this stuff. So the clinical guidelines and pathways. So we have not, I don't think, really updated this much in the past year because we've been doing EPIC, but there have been a few updates. So the one, I think, major one that we've kind of updated was the C. diff guideline. That is, well, it's just been recently updated or kind of agreed upon with the upstate. So this is one of the first of two system-wide agreed upon C. diff protocols, the one being C. diff, the other being surgical prophylaxis. And so this one being C. diff, it really is kind of the same thing that we've always been doing, vancomycin for your initial and then your recurrence, tapering for second and subsequent recurrences. Tapering is a little more streamlined than we used to do. It's a long taper, but it is a little bit more easier. It offers a less frequency dosing as the patient tapers. You can see the same thing with severe vanc PO plus flagyl IV. Few differences. Fidaxomicin is still an available option. It just had to come off the pathway because any restricted antimicrobial cannot be based up on pathways in the system. So if there is something that is restricted, it can be utilized potentially. And you can see the fidaxomicin is down here as a footnote off of this second or subsequent recurrence. So it is an option to do when you either can't do a taper or you fail a taper. Again, it just requires approval and has some recommendations at the bottom here. So again, it's not that we've taken fidaxomicin off, it just requires either PEDS, ID or GI approval, and then with certain other indications. So that's that. And then obviously you see we have fecal transplant at the bottom also is a potential recommendation that we have potentially. Right now it's kind of on standstill because of COVID and they're not releasing stool unless it is for critically ill last line therapy. So, but that is something that we have done and we have options for in the near future. So that's that one. That's kind of probably the most, again, newest and updated protocol. The other one, like I mentioned here, is the surgical prophylaxis. This is one that is gone into effect or has been approved by the upstate and the Midlands. And so it basically is what the process would be moving forward as far as if different surgeries, it gives the surgeon and then I guess anesthesiology is the gatekeeper. They're the ones who should enter in the orders. That's a process that is new to here, but as you can see, the different surgeries and then the duration. So it's a big change for our institution for a few things, one being the process of ordering and driving factors of antibiotics in surgery, but also the duration. So the duration is 24 hours post-op or no post-op doses for most infections or not infections, prophylaxis from surgery. And so that is obviously new from what previously we've always done. And so that's something that will be a learned process. And then the open fracture protocol, that when kids come in with traumatic fractures is in this pathway now. It really hasn't changed much, except I think instead of doing tobramycin, we do Cipro and alpha gram negatives for our type 3 infections, or fractures, and they go for 72 hours. So everything else on here is 24. Neck is 7 days, and then perf appies is 5 days. And so that again is different than what we've always done, but that is, again, this is evidence-based guidelines that have been vetted through both hospitals. So anyway, those are the two biggest guidelines that that are up there. Again, all the other ones are ones that have been kind of up there, and we've gone through those. So they are up on phformulary.net, and they are all on the app. So they all should mirror each other seamlessly. If you have any questions about that. The next thing is the antibiogram that I've recently updated here. This is for the isolates from 2020. Some, I guess, major changes that, not really major changes. There's not been many big differences. So if you look here, this is our pediatric population for Staph aureus. So total, we're at 55% of MSSA, and last year we were at 61%. So down a little bit on that. Again, we draw your attention to the clindamycin row or column. That is always the one that kind of, is the most affected recently by use and through MRSA and MSSA. So we're at 81% total. So if you have Staph aureus, there's an 81% susceptibility to Clinda, down from 82%. MSSA is 72, down from 74%, and MRSA is 91, down from 95%. So all of them are trending down again. So if we can reiterate, clindamycin is not a good option really at all for staph. Even at MRSA, it's dropping below that. Remember, we say 10% threshold is kind of what you would, if you can choose something better, and we do have better options for oral, we would recommend that. In some cases, you might not have a better option, but if you have an allergy and so forth. But again, clindamycin is just becoming more and more resistant to staph in general, and we're seeing that again this year. So just be mindful of that. If you don't know the flavor, don't use it. If you know it's MRSA, it's still above that threshold, but just be cognizant of what's happening. The biggest change, and I'll say this is pretty staggering from the differences, is the strep pneumo. So if you notice here, we have a 50% susceptibility pattern of penicillin IV for meningitis, which is not all that crazy. It's not always great, but last year was at 80% with 15 isolates. So this is the same amount of isolates. So 15 last year, 14 this year. So that all stayed the same, but the numbers went drastically down. So we have 50% here. Ceftriaxone is at 71%. It's the first time in a long time that we are below 80% in ceftriaxone, which means that previously it was at 93% in ceftriaxone in meningitis, and it had been above 90% for quite some time. And with that being said, I would always be a proponent for not using vanc with ceftriaxone for strep pneumo meningitis, because you wouldn't have to. I know we would, but that would not be the book answer, because our resistance was not bad. However, now we would recommend obviously using vanc with ceftriaxone, given this pretty staggering number that we have right now. So again, it's 1 year. It can obviously go back, and this could just be been a bad year, but it is kind of staggering. Again, even looking at the non-meningitis, we had 100% IV susceptibility last year. So that means anytime you used AMP IV or penicillin IV for pneumonia that was strep pneumo, you would have 100% coverage. It's down to 86%. But if you notice here, not much better with ceftriaxone at all. And so usually you potentially could pick up a few AMP resistant or penicillin resistant with ceftriaxone, and that's not the case right now. So, and this is pretty staggering as well, and that's 46%. So less than half of the PO amoxicillin is appropriate for coverage in our community-acquired pneumonia, which leads me to this. So this is what we have here now for amoxicillin. And so this is probably what I would say is the recommended dosing now. Given our strep pneumo that is in the community, at least until we see better, I would high dose our amoxicillin for community-acquired pneumonia. I know it's every 8 hours and it's not your standard 45 mg per kg Q12 hours, but this is what I would recommend doing. So 100 mg per kg per day, same daily dose, 90, 100, but giving it every 8 hours, you're going to get your pharmacokinetics are going to get you better penetration into the lungs, giving it that more frequent. But your bang for your buck is when you get to the gram. So it's the kids that are going to max out on your 33 mg per kg per dose. And you're going to be able to give them higher doses. So instead of just doing 2 grams per day, giving 1 gram Q12 hours, now you can give 1 gram Q8. So that higher dosing is going to be beneficial. So again, that would just be my recommendation or our recommendation, but that kind of goes with what we're seeing currently in our community. So the good thing is we do have some options that are very promising still. Obviously, our levofloxacin has not got touched by, or has not been touched by the resistance. So we're still at 100% there, and our bank's still at 100%. So good there. Azithromycin or erythromycin is on from 63 to 44%. So again, another nod to the azithromycin for ear infections and so forth. Don't do it. It's not doing any good. It's only getting worse. And so 44% there, and that kind of that. And that that plays out there. So, okay. Again, so this is just a rehash for the ID consult recommendations through ASP. These are a few things that, a few infections that are recommended for ID consults. Remember that stewardship and ID are different. And so CF, bone and joint, bacterial meningitis, necrotitis, skin and soft tissue, and staph bacteremia are always supported ID consultations based on evidence and for that fact, and then disagreements with ASP as far as kind of wanting a further eval from ID specifically would be another reason for specific ID consultations, or obviously more complex patients. So again, those are just kind of some recommendations there. Touch on the shorter is better topic. So again, this is a chart I love to kind of reference a lot. This is from Brad Spellberg. He's a ID physician out of USC in California, and he does a lot of research, pediatric and adult, in durations of therapy. And so you all have heard us talk a lot about this as you've had us on either rotation or we've come in and done handshake stewardship with y'all. Again, these are different diseases that have decreased duration based on randomized controlled trials. And the randomized controlled trials on the right side are the number of trials that have been done to support at least equal efficacy of shorter duration. And I'll tell you that there are a good amount of these randomized controlled trials that actually are pediatrics, specifically in CAB. Probably over half of them are actually pediatric. Sinusitis, I think there are a few. There's some osteo ones, obviously neonatal cognitive staph, bacteremia, and gram negatives. So they all have a pediatric component. So this is not just adult focused. Chronic osteo was led by pediatrics, and so is septic arthritis as well. But as you can see here, 3 to 5 days for CAP, 7 to pyelo. You've seen us talk 5 for intra-abdominal. That's kind of why we push now for 5, even instead of the 7 that we've always done. Gram-negative bacteremia, 7 days. Chronic osteos have really, come down for 6 to 12 weeks. Septic arthritis, 14 versus 28 days, and kind of so on. Sinusitis is 5 versus 7 to 10. The neutropenic with fever, we do the 80 afebrile times 72 hours instead of what used to be considered waiting for count recovery. So if you're just afebrile, now you can stop antibiotics. And again, if you've been in the NICU, we do 5 days now instead of 7 days for culture negative sepsis in our neonates. So that's, again, just some diseases or infections that have been shown to have better or just as good efficacy with about half of the duration. So something to keep in mind there. Diagnostic stewardship. So these are a couple of things we continue to see these kind of come up a lot, and so I like to kind of just rehash these. The meningoencephalitis PCR does include HSV and enterovirus, so there is, you don't have to order an HSV PCR CSF on top of that. It's included in that. So if you're going to do the ME panel, you don't have to order those separately. Respiratory viral panel, you don't have to order the SARS-CoV-2 and the influenza PCR with the respiratory PCR. I don't know if there's something, I don't know what's happening with Epic right now, but it appears that every time they're being ordered together. So I don't know if that's an order set issue, and maybe somebody else has that answer, but both tests are being ordered together right now. And again, there would be no need for that. Everything is on the one panel. Now, if you don't need everything else and you just want the SARS-CoV-2, influenza, and RSV, that's just a panel itself. Again, the mycoplasma is on that panel. So even though that's not a virus, it's on the respiratory viral panel. So don't miss that part that is on there. The GI PCR, which I still think is restricted and not done right now because of COVID, but C. diff is on that PCR. And then again, just a nod for the MRSA PCR to utilize that whenever we can try to de-escalate off of gram-positive or MRSA coverage. Procalcitonin, so just to kind of rehash this part, I am again trying to, I was told that 0.1 of being elevated was not going to be an epic, but it made its way there. And so I'm going to try again to make that right, because even in the comments, it says exactly this. So I don't know why we don't have that 0.5 as the cutoff, but 0.5 again is your cutoff. So anything less than that is very unlikely to be bacterial in origin based on a procalcitonin. 0.5 to 2 is localized or greater than 2. Really, you want to just know less than 0.5 is less likely to be bacterial. If you're using a procalcitonin for bacterial causes, greater than 0.5 has potential. Again, it is not a diagnostic marker. It is used for trending and shortening therapy. So what we always tell people is that if it is negative at presentation, that does not mean to withhold antibiotics. That's not how procalcitonin is been studied. It is a way to DC or shorten therapy once it has been started. So if it's negative, you always want to repeat 6 to 12 hours. And then if it is negative again, then you can consider stopping antibiotics and de-escalating. But again, do not start antibiotics if it is negative and you have a high suspicion of bacterial infection. So now, if it is negative and you have a viral cause, then fine. But if you're at a standstill and you don't know, start the antibiotics and just have a short leash to pull those off. 80% rule for duration is kind of what we like to use. It's been recommended by different expert groups that have looked at biomarkers and how to utilize them and trending of infections, and 80% of peak is kind of the overall kind of rule of thumb or recommendation from them. You don't have to order Q6, Q12 hour procalcitonin. They're a trending lab. And so you would use them every other day, every day if it's a quick turnaround. But again, never would it be after that first and that 12 hour, you never order it more frequently than that. Don't use it in babies less than 5 days. And again, consider repeating if it's negative. So there's these are always kind of what we talk about with when you're starting an antibiotic. Always want to keep thinking about these different Ds, as we would say. So you want to make sure that you're using you're covering the correct organism based on the differential that you have. It's the right drug based on the current guidelines that we have. So if you have an infection that is, you want to cover E. coli, making sure that you're using the best drug for that, the right dose, making sure that you're, like we talked about earlier on in the conversation, making sure that you're using the appropriate dose. So for amoxicillin, we talked about for pneumonia, making sure that we are using high dose potentially now because of to get into the lungs to get any of that resistant strep pneumo that is occurring. And then to de-escalate to the pathogen-directed therapy once cultures and susceptibilities are back. And then not over-treating to decrease the collateral damage of resistance and so forth. Here's just a penicillin chart. I'm not going to kind of go over that much, but as you can see, I have it here and I have it on our website page formulary. But just be cognizant of that. If a patient comes in, they have a penicillin allergy, as you can see, there's not much that crosses with penicillin or amox or amp, very little as far as the cephalosporins go. So if you have an amox allergy or a penicillin allergy, you can feel confident in utilizing a lot of the other antibiotics that we have as far as beta-lactams. So this is a slide we kind of we added in. We found it on Andy, I think, added this one. He found it pretty useful. So it basically just kind of goes through a lot of the history of antibiotics, and it's pretty interesting as far as the different progressions as we've developed antibiotics in 1942, I guess would be, or 35 with sulfa, but and where we're at today. And as you can see, the pipeline has been pretty steady from where we were at. So we have about 7 to 10 antibiotics in a decade that are developed. But right now we've had some good, I guess, headway with what's been developed. A lot of the stuff that has come out recently and is on that restricted drug list of beta-lactams are things that we're utilizing for CF patients, and not much so anymore, or not much out of that population in pediatrics right now. So there's not many of those that you all have had to kind of, have had too much exposure to so far. So I'm not going to kind of go into that. We'll talk about that during our orientation time. So with that being said, let me just skip here. What questions y'all have? Kind of went through a lot of the highlights. I have some, I have the other stuff here if y'all need it, but I think y'all have access to these as well. But any questions that y'all have? I don't want to leave time for questions. Yes.
Hi, so thank you. I was wondering, what would you recommend then? I think I missed it before. What was the recommendation for treatment of pneumonial meningitis then?
So vanc and ceftriaxone. So we would add that vancomycin now if we were considering strep pneumonitis. Correct. Now, like I said, that's kind of been the case that we've done here. That's been kind of standard practice. Our numbers supported potentially not having to add the vanc until this year because we were always above 90%. So we never had that issue here. Again, strep pneumo is one of those things that in one part of the state country can be very different than another part. So you always want to make sure no matter where you go to practice or where you're practicing, that's one thing that always has very distinct patterns. This is just the most alarming pattern we've seen to date. So
what about like the 25-day-old kid that has a normal bilirubin and comes in with a fever that we would usually just do Rocephin? Would you do Ampingent or would you do Rocephin and Vanc? Like, is Ampingent still fine because that age group it works?
Right. So yeah, so if it's a neo fever, Ampingent is still obviously a gold standard. Ceftriaxone can be utilized if if you just want to get one drug, or if you want to, yeah, I mean, but
do we trust just Rocephin now? Does that make sense?
But remember what you're covering, right? And so with fever and neonate, you are looking for GBS and E. coli, not strep pneumo. All right. And so that's why some people will do ceftriaxone, because there's some question whether or not there is more E. coli sepsis versus GBS. GBS sepsis is still number one, even though E. coli is coming up some. I prefer AMP and GENT in those fever, neonate with fever, because you get the synergy with the ampicillin and the gentamicin. Does that make sense for the GBS and for listeria, which is not very common anymore?
Yes.
So you gotta look why you're using the ceftriaxone.
Okay, so but in that situation, if for some reason you need to use ceftriaxone, you don't have to add on the vanc because we're not trying to cover for strep pneumo.
That's correct, right? Okay. If you're a fever and neonate, that is correct. That's not one of those big empiric bacteria that you are trying to cover for.
Thank you.
What else? This is y'all's time to actually talk to us. I just want to go through the antibiotics and read you what's on the screen. We wanted to be here to answer real life questions for y'all, because you can read antibiotics and, and we can, talk about them. But what kind of specific questions do y'all have?
Okay, I have a question. For strep pneumo ear infections, does that mean that we are changing the dosing to 3 times daily for that as well as the pneumonia, or what?
That would be our recommendation, just given the fact that our strep pneumo susceptibilities have changed. Remember, right, that recommendations are based on your local antibiogram. That's what Rob was saying. It's very regional with your strep pneumo susceptibility. But what he's talking about, if you do it Q8 hours, you get higher levels above your MIC for a little bit longer time. So you get better killing of the strep pneumo. So yeah, that's why we do an antibiogram, to kind of help change our management of what we do for treatment. And so it might, that's our recommendation. And also just the learning fact there, remember that ampicillin or amoxicillin is your strep pneumo coverage. Augmentin or Unison does not offer any additional strep pneumo coverage. What you're doing when you go from amoxicillin to Augmentin is covering for H. flu, that has beta lactamase producers, and MCAT. Come on, I know y'all got questions. Is that all that's here?
I have a question. Why is albendazole one of the drugs that we have to get like prior authorization? Because I had a kid with pinworms and I went to order it and it said that I needed like someone's approval.
Yeah, so this one's a system restriction. So it's expensive. It's not readily available at a lot of places. And so that's the biggest things. It goes on shortage a lot because of availability concerns. So that's one that is really just there to make sure that people in the ED aren't just kind of using it for any type of worm or what have you. There's other potential options for certain worms. So, which we have, I think, available on our pH formulary. But with that being said, if that is something like you went to order it and it needed approval, it should be a quick call. Just, I mean, you can just text us or what have you. But again, that's one that that's not going to be something we're going to stop you on, but it just needs to make sure that it gets a check through. So, yeah. Anything else? Too early to go.
Do y'all would you like this presentation? Did you send it?
I sent one similar, but I can send this one to you.
Yeah, we can send this one to y'all if you would like it. Can somebody confirm if you want us to send it out to Whitney? To send out? Okay.
I think you were asking, do you want us to
Oh,
have
okay.
the lecture, but we
Okay.
couldn't really hear you.
Oh, sorry. Yeah, she's not sent front. So do y'all want us to send this? We can send this to Whitney and I think she can distribute it.
Yes, please.
I recorded this for you guys too.
Oh, awesome. All right.
Anything else?
All right. So if y'all don't have anything else, I think I'll let y'all go early. That's okay.
Okay.
All right. Thank y'all.